A warm welcome to everyone out there. This is Dr. Madhushri and you are watching Homeo Science. Today we are going to discuss the importance of liver and also the anatomy of liver. That liver is a very important organ of our body as well as it is the largest gland of the body. Yes, liver is the largest gland in our body and it has got various activities to do like various metabolic functions to perform. It has got to secrete biles and etc. 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 So next let us see the basics, that is the weight of the liver. Weight of the liver, in case of male, it is 1.6 kg or 1600 grams, right? So in case of males, it is 1.6 kg or 1600 grams, whereas in case of females, it is 1.3 kg or 1300 grams. It can vary, but more or less, this is the weight of the liver. In males, it is 1.6 kg, and in case of females, it is 1.3 kg. Okay. Next, we have got to see the shape of the liver. Right. So, liver is basically a large solid organ, and it has got like a wedge shape. As you can see in the figure also, this this is like a wedge-like shape. So this kind of a wedge-shaped liver has got. This is the shape of the liver. Now let us see the situation or the location of the liver, and it's a very important thing to note. I hope all of us are acquainted with the different quadrants, 9 quadrants of the abdomen. So that I'm not going to discuss again here, but these are the three regions that liver is occupying, and that one must know. The one is the right hypochondrium here, and epigastrium, and also little bit a part of left hypochondrium also reaching up to the left lateral line. Right. So this is a left lateral line. This is the right lateral line. We all know this. This is the right hypochondrium. This is the epigastric region, and also this point it will reach to the left hypochondrium. So hypochondrium, the word hypochondrium means only under the ribs. So you can see the ribs here. Under the ribs, the liver lies, and in normal condition, please note this point, under normal condition, you cannot palpate the liver. Okay. So after we have studied the situation, now let us see the surface of the liver. Surfaces of the liver is a very important point that you must keep in mind, and there are 5 surfaces of liver, right? So there are 5 surfaces of liver which we will see one by one now. In one diagram only we can understand all the 5 surfaces of the liver. Point number 1, this point, surface of the liver. Diagram, you can see this in a better way. This quadrilateral area, this is the superior surface of the liver, point number 1. The inferior surface of the liver, right? And this is the anterior surface of the liver, the anterior surface of the liver, and this is the posterior surface of the liver, and this point. See the pointer moving along with the screen. This is the right surface of the liver. So these are the various 5 surfaces of the liver. Once again, guys, let us recall the 5 surfaces that a liver has. This one is the superior surface of the liver. In this diagram, you can see in a better way, this is a quadrilateral superior surface of the liver. This one is the inferior surface of the liver, right? This is the inferior surface of the liver. This is the right surface of the liver. See the cursor moving. This is the right lobe and the right surface of the liver this way. And this part is the anterior surface of the liver. And this one is the posterior surface of the liver. Right. So these are the 5 surfaces of the liver. Now, another very important point is a lobe of the liver. Now, if you have to study the lobes of the liver, then from anterior view, we have to study the lobes of the liver. One is from the anterior view, we have to study about the lobes of the liver. And is the second point is from the posterior view also, we have to study about the lobes of the liver. Okay, so from anterior view, there will be only 2 lobes of the liver that we have to study, that we will study. And in the posterior surface of the liver, if we see the liver from the posterior view, we will find 4 lobes of the liver that we will study now. This is the anterior surface of the liver, and as you can see, this is the falciform ligament here. So the falciform ligament is dividing the liver this way into 2 parts. Right, it is dividing the liver into 2 parts. This is the right lobe and this is the left lobe. Okay. Anatomically, as you can see, the right lobe is much bigger than the left lobe. This is only anatomical. Physiologically, it is nothing such. Now, as you can see, this falciform ligament, it is actually providing attachment to the anterior abdominal wall. Okay, so it is giving attachment to the anterior abdominal wall. So, in front of the liver, if you just see a human figure, in front of the liver, there is abdominal wall like this, isn't it? So, there is abdominal wall like this. And this falciform ligament, this is the falciform ligament. It is providing attachment with this anterior abdominal wall. It is providing the attachment of the liver with the anterior abdominal wall. Also, it is dividing the liver into right lobe and the left lobe. From the anterior view, we can see now we have got to do more in the posterior view. This is a posterior view of the liver. So this H-shaped, this diagram or this H-shaped structure, it is dividing the liver into 4 lobes. Understand, or we have to recognize the different fissure, different fossa and different grooves of the posterior surface of the liver. Only then we can better study the lobes of the liver. So this is a posterior surface. So this part will be the right lobe of the liver. And this part would be the left lobe of the liver. Right? So this is the right lobe of the liver and this is the left lobe of the liver. And this is the groove for inferior vena cava. In a normal person, in a living person, the inferior vena cava is present here like this. The inferior vena cava is present here like this. Wait for a second. Yes, it is present here like this. Cadaveric section, so that vena cava is taken out this surface, so hence this is a groove for the inferior vena cava. all these things. Let me rub it out. Okay. So this is a groove for the inferior vena cava. This is a fossa for gallbladder. This part, this way, this is a fossa for gallbladder. Now you can't see the fossa for gallbladder in this diagram because already the fundus of the gallbladder is present. Once you take out the fundus of the gallbladder, once you remove this fundus of the gallbladder, then you can see the fossa for gallbladder. Right. So these are the two parts. Now you could follow groove for IVC and the fundus or the fossa for gallbladder. This groove, as you can see, rather this fissure which you can see, this is a fissure for ligamentum venosum. This is a fissure for ligamentum venosum marked with this black arrow. You can see the pointer also. This is a fissure for ligamentum venosum, and this one is again a very bonus question that you have only to understand. This is a fissure for ligamentum teres hepatis. And this is the ligamentum teres hepatis itself. So in this diagram, it is already present. Okay, and you must know whether it is a remnant of left umbilical vein or right umbilical vein. This can be a well organized viva question for you. This is the ligamentum venosum, right? And from these two lips, you can see these two surfaces, rather surfaces. From these two surfaces, lesser omentum originates. From these two surfaces, lesser omentum originates. Right. And also from porta hepatis, from the lips of porta hepatis also, lesser omentum originates. And as you know, or you will study in the inferior surface of the liver, that stomach lies here like this. Stomach lies here like this. So, this is the lesser curvature of the stomach, and it is giving attachment to this one. This is a lesser omentum, which is originating from these lips. So, I hope it could be understood now. So, this is the importance. And now let us see. Right lobe we have already seen. Left lobe we have already seen. This is the caudate lobe which is present, and this is a quadrate lobe which is present. Now, if the question is asked or if you have to write an answer, you can very well write the location of caudate lobe. It lies between the groove for IVC and fissure for ligamentum venosum. You can see in the diagram very well. Same way in case of gallbladder on one side and this one fissure for ligamentum teres hepatis on the other side. You can see and then also you can write. Like if the view is clear, this diagram is clear with you, then also you can just memorize or you can just write it. Next, again, a very important point is the Riedel's law. Riedel's one. Now, it is not always necessary that you will find the Riedel's lobe when you will do the cadaveric dissection or in a normal person, but also it is nothing abnormal, right? A Riedel's lobe is not abnormal, it is just a normal variant, normal anatomical variant. So, this is a tongue-like projection this way. This is a Riedel's lobe. It is just a normal anatomical variant which is there, and it will not cause major pathology, not such major pathology in a human being, and it may be present or it may not be present. So that is of little importance, but if you are answering well, people may ask you, or you must know that. The second is very important part, that is relations of the liver. Now, relations of the liver is very important, and you have to understand two types of relation. That is, one is the peritoneal relation of the liver, and the other is the visceral relations of the liver. One is the peritoneal relation of the liver, and the other most important point is the visceral relation of the liver. Now, you have to understand what is this peritoneal relation. Peritoneal relation means the covering of the liver. Peritoneal relation means the covering of the liver. What is covering the liver? That is the peritoneal relation of the liver, right? That is only the peritoneal relation of the liver. And what is visceral relation means? If this is a liver, or this is a hypothetical diagram, right? If this is a liver, which viscera is in front of liver, which is behind the liver, and which is at the sides, or what are the structures which are present in front of the liver, behind the liver, and at the side. So that is a visceral relation, that is with the respect of the other viscera. And peritoneal relation means the covering of the liver. So let us see peritoneal relations. You have to understand one thing, that most of the liver, right, I'm using the word most of the liver, is covered by peritoneum, except a few areas which are not covered by peritoneum, and they are known as bare area. They are known as bare area of the liver. That is something you must know. What are the bare areas of the liver? Point number one, as you can see this surface on the superior side, or you may see on the posterior surface rather of the liver, this is a bare area of the liver on the posterior surface. This is a superior layer of the coronary ligament, and this one is the inferior layer of the coronary ligament, and this is the right triangular ligament, right? This part of the liver, this one is not covered by peritoneum. See the pointer as it moves. This part of the liver is little non-shiny than this, because this is covered by a covering and this is not covered. This is a bare area. There are many bare areas. This is one among them. Okay, this is bare area. So this is this part, which is the posterior superior layer of the coronary ligament. This is the inferior layer of the coronary ligament. This is the right triangular ligament, and this posterior surface, this is a triangular bare area. Be important to note. This is the first bare area. This is the first bare area. Area number 1. Now this is area number 2. If you remove the IVC, after that the area which you will get, that will be the bare area. Even if you see a peritoneum is covering here, then it will be covering like this, that is above the IVC. So the groove for IVC will not be covered by peritoneum, right? The groove for IVC will not be covered by the peritoneum. So again, this is another bare area. Point number 3 is the fossa for the gallbladder. You can see the gallbladder itself. So even if there is some peritoneal covering, even if you see the peritoneum is covering from here, if peritoneum is covering here or coming from here, then also the peritoneum will cover or go above, from above this gallbladder. It is not going to go under, from under this structure. So once you remove the gallbladder, the surface under that, that is a fossa for gallbladder, that will not be covered by the peritoneum. That will be another bare area. Now, lesser omentum is also covered as a bare area, right? So previously, this fissure for ligamentum venosum was also considered as a bare area, but nowadays it's not taken into consideration. That is not taken into consideration because some amount of peritoneum covering is still there, but lesser omentum has to be taken into consideration when you are talking about the bare area. And I just told you how is this lesser omentum originating from these two surfaces. This is a lesser omentum originating and also from the lips of porta hepatis. You can see this clearly, and here we have the stomach like this. the lesser curvature of the stomach, and it will get attached to the lesser curvature of the stomach like this. This is just a rough diagram. It's not very correct anatomically, but just to give you a rough idea, it is made so that you can get more or less a rough idea. So lesser omentum, you can say that it is coming under peritoneal relation, or it's coming under bare area, lesser omentum. And also the coronary ligament, that is having the superior and inferior layer, which enclose the bare area of the liver, they are also coming under the bare area of the liver only. This layer of this superior coronary ligament and this layer of this inferior coronary ligament, which is actually enclosing this triangular bare area. So this is coming under bare area only. Okay, so first bare area, it is present on which surface of the liver? Posterior surface of the liver. It is covered by superior layer of coronary ligament and the inferior layer of coronary ligament, and also the right triangular ligament, this one, as the pointer is showing you. Second most point is the groove for inferior vena cava, which is present in between caudate lobe that we have just seen in the previous slide, or here also we can see caudate lobe present between caudate lobe and also the triangular bare area. The next most point is this one, the gallbladder, or the fossa for gallbladder rather I should say, which is present in between quadrate lobe. This point you can see here also, which is quadrate lobe, and also you can see duodenal impression. So this, and also you have to consider this point, lesser omentum. You can't say the fissure for ligamentum venosum right now. You have to say lesser omentum, and also this point, this the layers of the coronary ligament itself, both superior and inferior layers, they are also included in the bare area since they are also devoid of peritoneal covering. Now let us come to the visceral relations of the liver. Now let us come to the visceral relations of the liver. So in a visceral relation, we have different surfaces. We have a superior surface, we have anterior surface, we have posterior surface, we have inferior surface, and also we have right surface. So all the 5 surfaces that we had read previously, if you can remember, we had read about the 5 surfaces of the liver. So now we have to study their visceral relations. We have to study their visceral relations. Which viscera is in front of them, who is behind them, and who is at the sides. So first we are going to begin from this one, from the superior surface. See, if we just draw the liver like this, we just draw the liver like this. It's roughly, it is like this. Diaphragm is going above the liver. Diaphragm is going above the liver like this. So two things you can see. Here is a concavity. Here is a concavity you can see. And here is a convexity that you can see. One concavity you can see, point number 1, and point number 2 you can see a convexity. I hope all of us know what is a concave. This is a concave surface and this is a convex surface. This part, this is a convex surface, and this part, this is a concave surface, forming a cave-like structure. So now see what are the structures present here. So heart will be present like this, and on the side it will be covered by lungs. I think till now nobody should have any problem. So there is, you can say, if you are talking about the superior surface of the liver, there is a concavity in the middle. There is a concavity in the middle, and at the sides there are convexities. There is a concavity in the middle part, and at the sides there are convexities. Superior surface of the liver will be. So in that concavity, in this concave structure, it will lodge the heart. So you will see a cardiac impression. Obviously, in this concavity, you will get to see a cardiac impression here. You will get to see cardiac impression here. Here you will see a cardiac impression. Right. And on this surfaces, you will see dome of the diaphragm. Lungs will obviously be present, but from that, if you say before that, dome of the diaphragm will be present. First, the dome of the diaphragm will be present, then above that, the lungs will be present. Lungs cannot come in direct contact with the liver. So, also, this is a point to be noted. Diaphragm separates the superior surface of the liver from the pleura and the lungs. Pleura is the covering of the lungs. Okay. So, diaphragm separates. This is a diaphragm which separates the superior surface of the liver from lungs and pleura. Whereas this middle surface, this concave surface, this separates the superior surface of the liver from pericardium. Okay? Otherwise, covering of the heart will come in direct contact with the superior surface of the liver if diaphragm were not there. The superior surface of the liver is, or this is how the relation of the superior surface of the liver. Now let us see the next. Let us see the anterior surface first, and then we can see the other surfaces, because the other surfaces are more important. It should be taken a little bit more time, but don't think this is also in any way little less important. Again, this is taken from the book BD Chaurasia. The anterior surface of the liver, any viscera, whether it is stomach, whether it is liver, anything, you have to understand anteriorly there is anterior abdominal wall. Anteriorly, what is covered here or what is present here? This anterior abdominal wall. So anterior relation of any viscera, there will be anterior abdominal wall, that is for sure. Even if you forget everything, you can just apply common sense and say that there is anterior abdominal wall. Number one. Number two is the xiphoid process. Since the liver is present under the chondrium, hypochondrium, so xiphoid process will come in relation with the anterior surface of the liver. Right, sternum xiphoid process, we all know this. Then diaphragm on both the sides. Right, diaphragm will just not cover only the superior surface of the liver. Diaphragm is going to cover this whole part like this. It's going to cover. So it's going to cover the anterior surface also. It's going to actually cover the liver. So it's going to cover the anterior surface also. That is it. Next in the list we have the falciform ligament. Of course, falciform ligament will also come in a relation of at the anterior surface. This is a falciform ligament. As you can remember that it was dividing the liver into right lobe and left lobe. This is a falciform ligament, so it will also be there. So once again, what are the structure? Number one is xiphoid process, which is there in the anterior surface of the liver. Second is anterior abdominal wall, which too will be common for any viscera, whether it's liver, whether it's stomach, anything. Anteriorly, anterior abdominal wall has to be there everywhere. The third is diaphragm on both sides. As you can say, liver is covered by the ribs also, and also it's under the ribs, so the name came hypochondrium, under the ribs. Even in normal condition, it's not palpable also. Right. Next is fourth one is the falciform ligament. Fourth one is the falciform ligament. This is a falciform ligament. So anterior surface is over. Next is the fissure on the inferior surface of the liver. We have already seen the different fissure of the liver. So we will just see the inferior surface of the liver. The structure on the inferior surface of the liver. First, as you can see, it's a quadrilateral area. Right, inferior surface is a quadrilateral area. It is directed downward, backward, and also to the left. It is marked by impressions on neighboring viscera. Right. So on the inferior side of the left lobe, so this is the left lobe you can see, and this is the right lobe you can see. See bare area here. It's so nicely drawn here. The bare area is drawn so nicely. This is taken from Gray's anatomy. Okay, this diagram is taken from Gray's anatomy, and this is a coronary ligament superior layer, and this is a coronary ligament inferior layer, or anterior posterior also you can say. This is the right triangular ligament, and you can see this is the bare area given so nicely in Gray's anatomy. Diagrams are really appreciable there. On the left lobe, as you can see the gastric impression here, it is there in the inferior surface. Okay, gastric impression is there in the inferior surface. You have a group for esophageal impression also in this. You have a group for esophageal impression also in this. The esophageal comes like this, and the stomach comes like this. This is the esophagus. This is the esophagus. It is how it comes. This is how only it will come. The stomach will be like this only, right? But it will be like this little bit. Just it's not good, but you have to just understand this. So this is a esophageal groove. Esophageal groove. It is there in the posterior surface. Esophageal groove is there in the posterior surface. Please remember that. Whereas gastric impression, the stomach lies or the gastric impression is there in the inferior surface. It is I. That is on the inferior surface of the liver. Please don't confuse between the surface of the liver. Okay? And the left lobe has a little raised area which comes in contact with the lesser omentum, that is tuber omentum. As you can see in this one, this will only come in contact with the lesser omentum here like this. This part, this is the tuber omentum, or you can say omental tuberosity. This is the tuber omental or the omental tuberosity structure. Number 2 that we can find in the inferior surface of the liver is that fissure called ligamentum teres hepatis. Here it is given as a fossa for left umbilical vein, and this one is fissure called ligamentum teres hepatis. Okay? That pass through the inferior border to the end of porta hepatis. This is a porta hepatis, you can see. This is the inferior border of the porta hepatis. Okay? From here, this one, fissure for ligamentum teres hepatis. Here it is given fossa for left umbilical vein. It will be gold. Okay? And this represents the obliterated left umbilical vein, which will be asked in MCQs. Quite expected. Next most important point is the quadrate lobe. This one. Its most important point is the quadrate lobe. It is there in the inferior surface of the liver. See, if this is a stomach, then this will. Yes, so we are going to discuss about the quadrate lobe, right? This is the quadrate lobe which is present here, about which we are going to discuss. So we talk about this. On one side we have this fossa for gallbladder. If we remove this gallbladder, we can see the fossa for gallbladder, and this one obliterated left umbilical vein, ligamentum teres hepatis. This one will be on the other side. This is the quadrate lobe. Now what we have to understand is the relation of the quadrate lobe. Right. So I told you yesterday also, in the previous session also, like this is a stomach which is coming like this. So you can just see here, this is the esophageal part. This is the stomach which is coming like this. So you can see here in this quadrate lobe, we can have the pylorus of the stomach. Point number 1. Point number 2, we can also have the first part of the duodenum and the lesser omentum also. Because see, this is porta hepatis, and lesser omentum originates from also these two lips also, and also from these two lips of the porta hepatis. These two lips of hepatis. So it is related, the quadrate lobe is related to point number 1, that is to the lesser omentum. Point number 2, that is to the pylorus of the stomach also. This is the pylorus of the stomach. And point number 3, that is to the first part of the duodenum. Now we have learned one thing in stomach, that the size of the stomach actually varies according to the amount of food present in it, or whether it's empty or whether it's full with food. So suppose when the stomach is empty, when there is no food, then it will shrink, right? If there is no food in the stomach, so it will shrink, as a result of which the pylorus, which is here now in a full stomach, it will shrink and come to this part little. So now the quadrate lobe will be related to the first part of the duodenum and a part of the transverse colon, right? So when the stomach is empty, quadrate lobe is related to the first part of the duodenum and transverse colon, a part of transverse colon, okay, of the gallbladder. This one I told you, if we remove the gallbladder, we can see the fossa of the gallbladder, which lies right to the quadrate lobe. This is the quadrate lobe, and the fossa of our gallbladder lies right to the quadrate lobe. Okay. Now to this fossa in the inferior surface, if you just see of the right lobe, inferior surface of the right lobe, there is colic impression for hepatic flexure of the colon, right? So here you can have the colic impression for the hepatic flexure of the colon. Also you can see here, this is a renal impression for the right kidney. Okay, so this is a renal impression for the right kidney, where the right kidney lies, and this is a duodenal impression which is for the second part of the duodenum. Okay, this is not for the first part of the duodenum. The first part is related to the quadrate lobe always, and this is the second part of the duodenum, which creates a duodenal impression here on this side. Right. Now we have to deal with little bit of the posterior surface also. Now from this part to this part, this triangular area that you can see, this is a posterior lobe of the stomach. So we have this bare area of the stomach, right, or the superior layer of the coronary ligament, inferior layer of the coronary ligament, and the right triangular ligament here. This is the non-peritoneal area, or the bare area, or the triangular bare area of the liver. This is present in the posterior surface, okay? And right here is suprarenal gland, lower end of the groove, for the IVC, this part. Now suppose if the kidney or the renal impression lies here like this, the kidney, right kidney, if it lies here, then obviously the suprarenal gland will lie like this. This will be the suprarenal gland. So of the bare area, this is how the gland will lie to it. Right suprarenal gland, right kidney, right suprarenal gland. Okay, it's near the lower end for the groove of IVC. You can see the groove of IVC, and it's near the lower end. This is how the kidney lies, and this is how the second part of the duodenum, it lies like this. The duodenum continues. This is the first part of the duodenum, and this is the second part of the duodenum, creating duodenal impression. Okay. The second most point important for the posterior surface is the groove for IVC. So this is a groove for IVC. You can already see it's very well shown in the figure. And in the upper part, if you just see of the vessel, the groove lodges the upper part, and the floor, this floor is pierced by the hepatic veins. Okay, so hepatic veins, this side they come and pierce this IVC. Okay, this is all what you have to know. Next is the caudate lobe, which is in the superior recess of the lesser sac. This is a caudate lobe which is in the superior recess of the lesser sac. Point number 1, it contains two layers of the lesser omentum. It contains two layers of the lesser omentum. From here the lesser omentum originate, and also from these two lips of the porta hepatis. So it is covered by those from the lesser omentum. Right. So one more point to be noted is that it's related to the crura of the diaphragm above the aortic opening. If this is like, you have to turn the liver. This is a posterior surface, so you have to just if we just see the anterior surface of the liver like this the abdominal aorta like this, or the celiac trunk which is coming like this, and this is just the anterior surface of the liver. If you just look at it like this is a falciform ligament which is coming and dividing. So caudate lobe will be somewhere in this area, like IVC will be somewhere like this, and so that is why the caudate lobe will be somewhere like in this area, right? So like a full it will be occupying like this side. So what are the structures that it will now cover? Now you have to just make a rough idea within the mind. So first part is, it is related to the crura of the diaphragm, because the diaphragm is present above like this. If this is a liver, the diaphragm will be present above like this. So diaphragm will be present above like this. Caudate lobe will definitely be related to the crura of the diaphragm. The caudate lobe will be definitely related to the crura of the diaphragm, that has to be there, and it is just above the aortic opening. Okay, it's just above the aortic opening. So we have just studied that what are the levels of inferior vena cava opening, at what surface of the diaphragm or at what level IVC is piercing the diaphragm and going up, at what level esophagus is piercing the diaphragm and coming down, and at what level abdominal aorta is piercing the diaphragm and it's coming down. So we should remember the different vertebral levels referring to it or related to it. That is 8. That the most easiest way that I used to remember is 8, 10 and 12. 8, 10 and 12. And that is voice of America. That is vena cava, inferior vena cava, now esophagus, figures, and this is abdominal aorta. So this is how you can remember, and this caudate lobe is related to this opening of the abdominal aorta. Okay. That is point number 1. The point number 2 is the diaphragm and the crura, which it is related to. Point number 2, and the point number 3 is the inferior phrenic artery and the celiac trunk. All these things. So actually it is related to the diaphragm above the aortic opening, and to the right inferior phrenic artery, and also to the celiac trunk, which is already discussed in the branches of the abdominal aorta and the blood. The previous figure, we can see the fissure for ligamentum venosum, that is deep, and it extends to in front of the caudate lobe. It contains 2 layers of the lesser omentum. The ligamentum venosum lies on its floor. Fissure for ligamentum venosum. From here, lesser omentum is coming up from these 2 legs, and also from these 2 legs of porta hepatis. And on the floor part of this one, of this fissure, ligamentum venosum lies. That is where ligamentum venosum lies. Ligamentum venosum is a remnant of ductus venosus of fetal life. Okay, so that is why in this figure they have written fossa for ductus venosus. That is why in this figure they have written fossa for ductus venosus. It is there in fetal life, but in case of adult we call it ligamentum venosum. So anyone you say that is right, but if you are writing ligamentum venosum, please mention that it is a fetal period that we are talking about, because in adult life that tends to degenerate. Right. It is connected below the left branch of portal vein above the left hepatic vein near to its entry in the vena cava. So that is the part. Next is the posterior surface of the left lobe, which is marked by the esophageal impression, esophageal groove that you can see. It is in the left lobe. It is there in the left lobe. So left lobe basically contains the stomach. So definitely now it is going to contain the esophageal impression. The esophagus is coming like this, and now this is the gastric impression for the stomach. So we are seeing the posterior surface, that is why it will be containing just like this. It will occupy the space like this. Now we have seen the posterior surface, we have seen the anterior surface, we have seen the superior surface also, and we have discussed the inferior surface also. Now we will see the right surface, for which we are waiting so long and which is coming in the middle so much. That is the right surface. So it is some kind of a quadrilateral area that you can just see in this diagram also, quadrilateral area, and it has got some medical importance. So that is something you must note. It is related to the diaphragm from 7th to 11th ribs in the mid-axillary line, which is very clearly shown here, 7th to 11th rib in the mid-axillary line, that you can see. Now what you have to understand is a different level. It is separated by diaphragm from pleura up to 10th rib, as you can see. Right, postrophrenic pleural recess, and this is the diaphragm. So it is separated at the 10th rib, that you have to understand. And the lungs, and it is separated from the diaphragm from the lungs up to 10th rib, up to 8th rib. This is the level of the lungs. It is separated from the diaphragm from the 8th rib, and from the this diaphragm it's till the 10th rib. But you have to understand the upper 1/3 of the surface is related to the diaphragm, the pleura and the lungs. The middle is related to the diaphragm and the postrophrenic recess of the pleura, which you can see in the diaphragm, and the which in the diagram, and the lower 1/3 to the diaphragm alone. So diaphragm will actually, it's a very big structure, so it's going to cover everything. But if you just see apart from the diaphragm, so always you have to mention. But other than that, if you see the first part, it is related to the lungs and also to the pleura. Pleura is nothing but the covering of the lungs. So lungs and pleura and diaphragm, these are the structures with which the upper 1/3 divide this area, the right surface, into the three parts. That is upper 1/3. We are just dividing it hypothetically. We are just dividing it into upper 1/3. We are just dividing into middle 1/3, and we are also dividing it into lower 1/3. We are just dividing it into lower 1/3. So what are the structures that upper 1/3 will contain? You can well see, very well appreciate in the diagram, that is in the, this is the upper 1/3 will contain, that is the right lung as well as the pleura, because pleura is nothing but the covering of the lung. Diaphragm will be related to that. Now coming to the middle portion, that you can see diaphragm, and also you can see one more thing, that is the postdiaphragmatic recess of the pleura. Continue, this is it, that you can appreciate the right postdiaphragmatic recess of the pleural recess of the pleura. So that is till here. This is the first part. First part. This is a second middle 1/3. This is a middle 1/3, and this is a lower 1/3. Lower 1/3 is related to the diaphragm alone. Right. So lower 1/3 is related to nothing but the diaphragm alone. Now, what is the purpose of studying this? What is it has got some technical importance that we have to understand. During draining of pleural abscess or any kind of pleural effusion from the pleural cavity, you must know where you have to place the needle or where you have to pierce the needle if you have to take the fluid from pleura. like in case of pleuritis, in case of pleural effusion, etc. There are many conditions where you have to take out the pleural fluid, even in case of pneumothorax also, in case of tension pneumothorax also. Point number 2 is that during liver biopsy, if some conditions arise where you have to take the liver biopsy, then you shouldn't insert the needle in such a way that it will hamper or it will cause harm to the lungs or to the pleura. So you have to insert it like this, where liver needle biopsy is passed through the right 8 intercostal space. Although you can see this is the right side, even if I don't mention it to be the right side, you can well appreciate that it is the right side of the body. So from this part, that is the right intercostal space, you have to insert the needle or you have to pass the needle if in case you have to do the liver biopsy. Why? Because it's transversal for the pleural and the peritoneal cavity. So as a result of which, it's not going to harm any part of the body. It's not going to harm any part of the body. It's not going to pierce the lung. If you just pass the needle from here, you can't randomly pass the needle from anyone. If you pass the needle from here, it will damage the lungs. If you pass the needle from here, it will damage the pleura. So you have to be selective that at what level you have to pierce the needle if you want to take out or if you want to do liver biopsy, or if you have to take out the fluid during pleural effusion, or in case of tension pneumothorax or any important condition, clinical condition. So this is a clinical importance that you have to know about the right surface of the liver. Okay, so that is it. Now, and again, a very important part that we have to study, that is a porta hepatis. Already we have discussed about the structure of porta hepatis, but in this slide we are going to deal with something more. That is, it is consisting of, because this is an area from where questions are mostly asked, and also you. Point number 1 is portal vein, that you must know. This is a portal vein that comprises porta hepatis. Point number 2 is that hepatic artery, that also comprises porta hepatis, and the third one is the hepatic duct, that also comprises the porta hepatis. So please don't confuse whether it's hepatic vein or portal vein. It's portal vein, it's hepatic artery, and it's the hepatic duct. So all these things comprise the porta hepatis. Now moving on to the next slide, because we need to see the diagram of porta hepatis. This is how it looks in the cadaveric section. Portal vein. See the direction of the arrows, that you have to understand that vein, so it's going inside and it's dividing into hepatic veins, and which ultimately drain into the IVC. Because portal vein, please remember that don't say that it drains into the IVC. Directly it does not drain into the IVC. Point number 2 is a hepatic artery. Obviously artery will bring blood to the liver, right? So it's going to bring blood to the liver. So the direction of the arrow is like this. And the next part is that this hepatic duct, so it is bringing the bile out from the liver. So the direction of arrow is opposite in this case, because it's going to bring the product from the liver to outside, whereas it's just the reverse in case of the others. Now in the next diagram, things will be more clear. Right, so this is a hepatic artery, this is a portal vein, and this is a common bile duct. So these are the three structures which are doing the or comprising or forming the porta hepatis that you have to remember. So this is the first part. Thank you so much for watching.